The major thrust here is going to be head neck cancer, cancer of the oral cavity, larynx, skull base, but my personal interest is more into thyroid cancer. And they have two big sessions on thyroid cancer here. One of them will be moderated by me, and I gave a talk this morning on management of the neck in thyroid cancer. As everybody knows around the world, the incidence of thyroid cancer has risen quite a bit. In the United States, it has gone up almost 5 times. In Korea, it's almost 15 times more. And most of these are what we call as micro-carcinomas or small thyroid cancers. Majority of the people would have lived with them, but now with our investigations such as ultrasound, CAT scan, and other investigations, we find these tumors early. Once we find the tumors, we get appropriate investigation, which includes an ultrasound, a needle biopsy, and treatment. Majority of these are treated surgically, which is generally a limited thyroid operation or a lobectomy. Lately, we have been quite interested both at Memorial and the rest of the world to see if we can manage these patients like prostate cancer, just observation and follow up every year. If there is a major change in the size of the thyroid cancer, then go ahead and operate. This is a new approach, and only because most of these tumors, patients would have lived with these tumors without doing anything, except that we had done the investigation, incidental finding. This is what we call as incidentaloma of the thyroid. It's an incidental finding which we find out as thyroid cancer, and then there is a lot of debate whether we should operate or not. Our current interest is to observe these patients, what we call as small tumors, microcarcinomas. And we have been very happy with that. Yes, that's what we call today overdiagnosis and overtreatment of thyroid cancer. And this is going to happen much more the more investigations we do, the more ultrasounds of the neck, the more CAT scans, the more MRIs, the more PET scan, we're going to find more tumors. The million-dollar question is, does everybody needs to go to the operating room, or can we observe some of these patients? If you are going to observe the patient, it requires a lot of understanding from the patient, the family, and the referring physician who has sent the patient for surgery. Is this truly a rise, or we are digging into the iceberg, which would have been potentially silent for a long time? Remains somewhat unclear. Are there environmental factors? Is there a child getting a radiation as a young kid, or dental x-rays? We don't know that. None of these etiological factors or supposedly etiological factors have been confirmed. The two issues, the Chernobyl nuclear accident and the Japanese nuclear accident, we have seen an increase in the incidence of thyroid cancer, especially Chernobyl because it was a long time back. The Japanese accident occurred in 2011, so we will have much more time to find out what happens to these individuals. There is a lot of interest now in treating these patients with radioactive iodine in selected patients. What has changed in the last, I would say, 10 years is a selective, personalized, and precision treatment of these tumors. So it's not, it's a hammer and nail philosophy. I want to do this because I can do it, that's why we do it. It has changed quite a bit. We now treat these patients, number one is observation, number two, limited surgery. We don't do a total thyroidectomy on everybody. And the American Thyroid Association, which is a major organization coming up with the guidelines, has endorsed the philosophy that limited surgery is quite appropriate. We are using radioactive iodine in very selected patients. And there is more and more interest today, at least in the United States, in patients with advanced cancer, where we don't have any modality to treat them with targeted therapy. These are the therapies which are based on the evolution and progression of thyroid cancer based on molecular changes. So now we target those molecular changes with newer therapies such as sorafenib, vandetanib. These are the new drugs which are now FDA approved and used for thyroid cancer.
you.